Good morning, everyone. Thank you for being here today. Let's step into a rhythm that both fascinates and challenges us. Atrial fibrillation with rapid ventricular response, or AFib with RVR. Picture a patient whose heart races unpredictably at 160 beats per minute, a pulse that feels like a hummingbird's wing, palpitations that trigger dizziness, shortness of breath, even chest discomfort. That's the urgency we'll master today. First, let's set the stage. Atrial fibrillation is the most common sustained arrhythmia in our practice, defined by chaotic atrial electrical activity and an irregular ventricular response. When the ventricle tries to keep up at rates over 120, 150 beats per minute, we call it AFib with RVR. It can be brand new, an acute onset, or a long-standing paroxysmal dance that flares unpredictably. Triggers range from heart failure and ischemia to hyperthyroidism, infection, or even a weekend of heavy drinking, what some call holiday heart. Diagnosis begins instantly. The moment you suspect AF with RVR, grab that 12-lead ECG. Look for absent P waves, fibrillatory F waves, and wildly varying RR intervals. Confirm the rate, often above 150, and rule out lookalikes like multifocal atrial tachycardia or flutter with variable block. If in doubt, extend your view with telemetry or a longer rhythm strip. Next, assess hemodynamic stability. Is our patient perfusing well or slipping into shock? Check blood pressure, mental status, signs of acute heart failure, rales, jugular venous distension, or ongoing chest pain that hints at myocardial ischemia. If you see hypotension, pulmonary edema, altered mentation, or refractory chest pain, you have an unstable AFib. That patient needs synchronized cardioversion right now. For every patient, stable or unstable, a focused history and exam guide our next steps. Ask, when did the palpitations begin and how long have they lasted? Do they have known heart disease? Any triggers, fever, thyroid symptoms, binge alcohol, or missed medications like beta blockers or digoxin? On exam, you'll find an irregular pulse, variable intensity of heart sounds, and perhaps signs of thyrotoxicosis, a trembling hand, a goiter. Always perform a brief neurologic check too. AFib can seed strokes into the cerebral circulation. Laboratory evaluation hunts for reversible causes. Check TSH and free T4. Hyperthyroidism can drive AFib. Measure electrolytes, especially potassium and magnesium, correcting anything low to stabilize the myocardium. Draw troponin to uncover demand ischemia or a hidden acute coronary syndrome. If infection is suspected, send a CBC and cultures. If stimulant use is possible, consider a tox screen. Imaging and echo help refine our understanding. A bedside echocardiogram, though not emergent, reveals ejection fraction, atrial size, and valvular pathology. If you suspect a pulmonary embolism as the culprit, follow your PE protocol. A chest X-ray can show heart failure or alternate causes of dyspnea. Stroke prevention must be woven into our plan from the start. Calculate the CHA2DS2-VASC score to gauge thromboembolic risk. If AFib has persisted for more than 48 hours or its duration is unknown, and you plan cardioversion, you must anticoagulate to avoid dislodging atrial clots. We classify each episode as first detected, paroxysmal, persistent, or permanent, and note any underlying causes that demand treatment: sepsis, thyrotoxicosis, or alcohol intoxication, because eliminating triggers often restores rhythm. Now, let's treat unstable AFib with RVR. Prepare for immediate synchronized cardioversion. Sedate with midazolam or etomidate. Ensure sync is on and deliver a biphasic shock at 100-200 joules. If necessary, ramp up energy and repeat. In parallel, support airway and blood pressure with oxygen and vasopressors as needed. If time permits, and without delaying life-saving shock, give a heparin bolus 70-100 ukg, knowing cardioversion can mobilize clots. Once you've restored sinus rhythm, maintain anticoagulation as indicated. Stable AFib with RVR. Our first goal is rate control, diltiazem, 0.25 mg/kg over 2 minutes, often around 15 to 20 ml. If the rate remains over 100 after 15 minutes, give a second bolus of 0.35 mg/kg and start an infusion at 5 to 15 mg/hr. Watching for hypotension. IV beta blockers, metoprolol or esmolol. Metoprolol, 2.5 mg IV Q5 min up to 15 mg total, or an esmolol infusion for rapid titration. Ideal when tight control is essential. Avoid beta blockers in acute decompensated heart failure or severe asthma. IV digoxin. Although slower, onset 60 minutes, 0.5 mg IV, followed by up to 1 to 1.5 mg total over 24 hours, can help in hypotensive patients or those with heart failure. Amiodarone. Load with 300 mg over 1 hour, then 900 mg over 24 hours. It slows the rate and may cardiovert, but use caution if AFib has persisted beyond 48 hours without anticoagulation. Should rate control fail, or if the patient is young, symptomatic, and within 48 hours of AFib onset, we consider rhythm control. Electrical cardioversion under sedation. Again, 100-200 joules, with pre- or post-shock anticoagulation. Pharmacologic cardioversion, IV ibutylide 1 mg over 10 minutes, repeat once, or prokinamide 15 to 17 mg at 20-50 mg min, especially in patients with accessory pathways like WPW. Flecainide or propafenone can be used in structurally normal hearts. Always monitor continuously, ready to switch to electrical cardioversion if needed. Anticoagulation runs alongside. For AFib, 48 hours or unknown duration, start full heparin or low molecular weight heparin before any shock, and plan for at least 4 weeks of anticoagulation afterward. For new onset, low-risk AFib under 48 hours, you can often cardiovert first, but still initiate a DOACI before discharge if indicated by the CHA2DS2 VASE score. Don't forget to treat the underlying cause, be it sepsis, thyroid storm, pulmonary embolism, alcohol withdrawal, or electrolyte imbalances. When the trigger is neutralized, many patients reconvert spontaneously within 24-48 hours. Observation on telemetry helps us ensure stability. Those who remain rate-controlled, symptom-free, and with triggers addressed may be discharged with clear instructions, adherence to anticoagulants and rate control medications, recognition of palpitations or breathlessness, and an early follow-up appointment. Others, unstable patients, those requiring IV drips or with new heart failure or ischemia, need admission to a monitored bed, perhaps even the ICU. Finally, special considerations. In WPW with AFib, Avoid AV node blockers entirely. Use procainamide or immediate cardioversion. In HFrEF, avoid calcium channel blockers, opt for beta blockers or digoxin, and consider amiodarone. In drug toxicity, for example, digoxin toxicity, treat with the appropriate antidote like digoxin immune fab. In closing, our approach to AFib with RVR is a choreography of swift diagnosis, thoughtful rate or rhythm control, vigilant anticoagulation, and targeted treatment of triggers. Each step guards the brain from stroke, the heart from failure, and the patient from harm. Thank you for your attention. Let's now discuss any questions or share experiences that can sharpen our skills even further.